Welcome to the Deep Dive. Today we are putting on our metaphorical surgical scrubs and traveling back to a pivotal moment in medical history.
Yeah, we are.
We are embarking on a high-stakes mission, really, to identify the single most seminal article published in vascular surgery over the last 100 years.
It's a beautifully contentious starting point, I think,
Right.
because immediately you run into this core intellectual conflict that really defines a lot of medical literature. What exactly does seminal mean here?
Yeah, what are we really looking for?
Are we talking about the most referenced paper, the citation heavyweight that defines every standard of care guideline today?
Or
Or are we looking for the article, often small, often pretty controversial at the time, that triggered the biggest, most undeniable conceptual paradigm shift?
that distinction is, well, it's everything, isn't it? The biggest conceptual breakthroughs, they usually start small, don't they?
They do, often just initial case series. Brave ones.
Presenting an idea that just breaks all the rules. And then the definitive large-scale papers that follow, the randomized controlled trials, the RCTs with thousands of patients, those are the ones that rack up the citations.
Exactly. Because they validate the concept, they make it reproducible, standardizable.
So we have to decide, are we looking for that revolutionary foundation stone, the idea that made the whole specialty kind of gasp?
Or the robust cathedral of evidence that gets built on top of it years later.
And for this deep dive, we're taking a stance, aren't we?
We are. Our deep dive takes a firm stance that the most seminal contribution is the one that forced the entire field to fundamentally redefine itself, period.
And that leads us pretty directly, actually, to the source material that represent that central paradigm shift. The very first paper introducing endovascular aneurysm repair, or EVAR.
The game changer. That source is Parodi, Palmaz, and Barone, published in the Annals of Vascular Surgery back in 1991. The title was Transfemoral Intraluminal Graft Implantation for Abdominal Aortic Aneurysms.
This is the article. And our mission for you, the listener, is to unpack in, well, exhaustive detail why this piece of work, which was essentially a brave case series describing the initial treatment of just 5 patients.
That's 5.
Why it wasn't merely an iteration on existing techniques, but a seismic, full-scale revolution. One that drew a line in the sand for how vascular surgeons trained and operated from then on.
It truly was the dividing line. I mean, to understand the magnitude of this shift, you really have to picture life before 1991.
Okay, set the scene.
If you were diagnosed with a large, threatening abdominal aortic aneurysm, AAA, your only option, your only real durable option, was a massive high-morbidity open operation.
And we're talking major surgery here.
Oh, yeah. A lengthy transabdominal or maybe retroperitoneal incision, mandatory aortic cross-clamping. You had to stop blood flow to the lower half of the body for a while.
Which is a huge physiological hit.
Huge. And incurring a significant physiological trespass, as they called it, that took a brutal toll on the patient system, especially older, sicker patients.
We're talking about massive surgery with weeks, potentially months of recovery. And for those high-risk patients, a very real chance of not making it off the table.
Absolutely. The operation itself, when successful and performed by experts like Charles Dubost, who pioneered it in the 50s, was an incredible surgical achievement, no question.
Right.
But its inherent invasiveness placed enormous pressure on the cardiovascular system, the renal system. Parodi's work just flipped that script entirely.
How so?
By introducing a technique that treated the aneurysm from within the vessel using a catheter threaded up from the groin, it marked the precise moment the established classic open era was forced to begin yielding ground to the modern endovascular or maybe hybrid era of vascular surgery.
Okay, so let's establish the foundation right away. This crucial distinction between the concept and the evidence. We know this groundbreaking concept paper isn't the most cited one.
That's a crucial acknowledgement, yeah. We have to be upfront about that. The Parodi 1991 paper, revolutionary as the idea was not the most cited article in vascular surgery. Not by a long shot, actually.
And this brings us back to that core tension we kicked off with, right?
Exactly. Seminal concept papers, they introduce the paradigm-smashing idea. The highly cited papers, they are overwhelmingly the massive, multi-center, randomized controlled trials, the RCTs that come years later.
The ones that robustly validate or sometimes complicate the initial procedure.
Right. And, most importantly, they establish the standard of care for global adoption. That's key.
RCTs are the documents that doctors, practitioners are legally and ethically obliged to cite when justifying a treatment choice. They're the definition of evidence-based medicine.
Precisely. They are the citation heavyweights because they carry the statistical power of large cohorts. So for instance, if you look at papers that define therapeutic standards today, the citations belong to those landmark trials.
Can you give us some examples? Those evidence heavyweights that came out around the time Parodi published, or maybe shortly after.
Sure. In the cerebrovascular field, so strokes and TIAs, you have the NASCET trial, North American Symptomatic Carotid Endarterectomy trial, and the ECST, the European Carotid Surgery trial. Both published right around 1991, actually.
Okay.
These trials definitively proved that carotid endarterectomy, a core open procedure, was highly beneficial for symptomatic carotid stenosis. They are cited endlessly because they gave surgeons the hard statistical backing to operate and defined, the threshold of disease that needed intervention.
So they validated the concept of open carotid surgery, which was already established, but needed that large-scale proof.
Exactly. And then specific to the EVAR world that Parodi opened up, the later large-scale comparative trials like EVAR-1 in the UK, the DREAM trial in the Netherlands, and the OVER trial in the US, those are now cited far, far more heavily than Parodi's original paper.
Because they compared the new method to the old one head-to-head.
Precisely. Parodi introduced the method. These trials compared that method against the established open repair in large numbers of patients.
And what were the key findings of those big comparison trials? The ones that made them so crucial and highly cited. Can't just drop the acronyms, right? We need the substance.
Excellent point. What made these trials citation magnets was their nuanced findings. They weren't simple yes or no answers. Initially, they all confirmed that EVAR had a massive benefit in terms of operative mortality.
The early death rate.
Yeah, the 30-day death rate was significantly lower than open repair. That was huge.
But there's always a but, isn't there?
There often is in medicine. The trials also showed a critical long-term caveat, that initial survival benefit. It tended to diminish over time.
Why was that?
Largely due to complications requiring reintervention, things we now call endoleaks, where blood gets back into the aneurysm sac, or device migrations. And also, perhaps a phenomenon related to the fact that the patients selected for EVAR early on were often inherently frailer to begin with.
Okay, so the RCTs validated the short-term safety aspect of Parodi's concept, which was massive. But they introduced this long-term caution about device durability and the absolute need for ongoing surveillance. That duality makes them highly citable.
Absolutely. Because practice guidelines have to reflect both the benefits and the risks. And then, of course, topping citation charts are the clinical practice guidelines themselves.
Right, the summary documents.
Yeah, the documents produced by groups like the SVS, Society for Vascular Surgery, the SVS, European Society for Vascular Surgery, or the AHA-ACC, American Heart Association, American College of Cardiology. These guidelines synthesize all the evidence, they're updated regularly, and essentially every researcher or clinician writing about the topic has to cite them.
They become citation vortexes, as you said.
Exactly. But they are not the point of origin. Parodi is the point of origin for the EVAR revolution. That's the key distinction we're making.
Okay, so to fully grasp the magnitude of Parodi's synthesis, we need to understand the two conceptual pillars that came before him, the ones that sort of enabled his work. Let's start with the first honorable mention, the establishment of open cerebrovascular surgery.
Right, we need to travel back a bit further for this one, to 1954. And the seminal work by Eastcott, Pickering, and Robb. This paper essentially established the entire field of surgical treatment for cerebrovascular disease. It's foundational to the whole concept of extracranial vascular surgery.
So before that, were strokes and TIAs, transient ischemic attacks, were they not fully understood to be linked to surgically fixable problems in the neck arteries?
Not definitively, and certainly not practically in terms of treatment. I mean, surgeons treated brain lesions, they treated cardiac issues, but the Eastcott paper was the landmark proof that carotid artery stenosis, that narrowing of the major artery feeding the brain, was directly responsible for TIAs and stroke.
And
critically, it showed that performing a carotid endarterectomy, or CEA, basically cutting out the plaque buildup, was a surgically correctable and beneficial intervention. It actually worked.
That's fundamental, isn't it? It established the principle that a localized arterial disease way up in the neck could be safely and effectively accessed via open surgery to prevent a devastating neurological outcome like a stroke.
Precisely. It gave birth to the carotid endarterectomy, which became one of the most important operations in vascular surgery, and initially one of the most fraught, with high complication rates until techniques were refined. It defined the high-stakes, open, classic surgical standard for the upper body vasculature, that's Pillar 1, defining the open extracranial domain.
Okay, Pillar 1 established. Now for Pillar 2. The conceptual Big Bang that established the, well, radical idea of treating arteries without an incision at all. The birth of endovascular intervention.
Yeah, yes. That is the Daughter and Judkins paper from 1964, Transluminal Treatment of Arteriosclerotic Obstruction. Charles Daughter, who was a truly visionary interventional radiologist at the University of Oregon.
A radiologist, not a surgeon. That's key.
Crucial point. He performed the first percutaneous transluminal angioplasty. He used these coaxial catheters, basically tubes nested inside one another, to mechanically dilate a stenosis, a blockage in the superficial femoral artery of a patient who was otherwise facing amputation.
So angioplasty was born right there. This is the absolute conceptual origin of all modern percutaneous endovascular intervention, isn't it? From heart stents to fixing leg arteries, it all starts here.
Absolutely. You have to think about how radical this was in 1964. Surgery reigned supreme. The idea of blindly threading, rigid plastic tubes into an artery, pushing through calcified plaque and mechanically stretching the vessel wall. It was considered sheer lunacy by the established surgical community.
Why such resistance?
Well, it flew in the face of centuries of surgical wisdom. The principle was, to fix a pipe, you cut down to it, you open it, you inspect it directly, and you patch it or replace it. You don't just ram a bigger pipe through the blockage from the inside.
So how extreme was the backlash then? The sources mention the phrase, daughter's folly. That sounds pretty dismissive.
Oh, the skepticism was ferocious. The surgical establishment, which had painstakingly established the safety and necessity of open procedures like the Eastcott operation for carotids, they saw Daughter's technique as reckless, unproven, dangerous, maybe even a step backward toward those old, discredited wiring and wrapping techniques for aneurysms that never worked.
What were they specifically afraid of?
They feared it would cause acute rupture of the artery or catastrophic distal embolization, sending clots downstream and blocking off circulation further down. To be called Daughter's folly meant the procedure was seen as a ridiculous, non-serious attempt that would inevitably lead to disaster.
And yet,
it took decades, but the medical community eventually had to embrace the reality that Daughter wasn't a fool, he was a prophet.
this is a perfect setup then. Eastcott established the standard for high-stakes open vascular surgery. Daughter established the radical, politically contentious, but technologically necessary concept of endovascular access and angioplasty.
And Parodi's genius, in 1991, was connecting those two seemingly incompatible worlds. It was audacious.
How so?
He took the despised, dismissed endovascular concept from Daughter, the radiologist, and applied it to the specialty's most central, defining, and lethal disease, the abdominal aortic aneurysm, which, until that very moment, could only be treated by the method defined by Eastcott's open surgical successors.
It was fusion.
It was the audacious fusion of the two greatest conceptual leaps in vascular treatment history. Mind-blowing, really.
Okay, let's move into the clinical landscape of the early 1990s then, and detail why a less invasive solution was so critically, desperately needed for managing AAAs.
Yeah, the need was absolutely profound. I mean, AAA has been recognized as a lethal process for millennia. We knew it killed people.
But the treatments were lacking.
Exactly. Early treatments were rudimentary, as you mentioned. Things like external wrapping, trying to reinforce the wall, or intraluminal wiring, trying to induce thrombosis, make it clot off from the inside, or even ligation, tying off the aorta above the aneurysm to stop flow.
Did any of those work long-term?
No. These historical non-resection treatments all proved fatal in the long run. The artery would just dilate above the ligation point, or the wrapping would fail, and eventually it resulted in rupture. Game over.
So the surgical community accepted the extreme morbidity, the harshness of the open operation because it was the only way to achieve durable exclusion of the aneurysm by replacing it with a graft, as pioneered by Dubas back in the 1950s.
Exactly. Elective open AAA repair, when performed in experienced centers on relatively healthy patients, is a triumph of surgery. It offers excellent long-term survival with operative mortality often under 5%. That's good.
But the patient population was changing, wasn't it?
Severely. By the 1990s, vascular surgeons were dealing with an increasingly aged population. The true incidence of AAA was clearly rising, especially according to autopsy studies. More people were living long enough to develop them.
And when you combine an aging population with a massive physiological trauma of open aortic surgery, you create a crisis.
A deadly crisis. Because these older patients frequently suffered from multiple severe comorbid conditions. Things like non-correctable myocardial ischemia, bad heart disease, or severe cardiomyopathy, weak heart muscle, or significant pulmonary disease, COPD, emphysema, or renal insufficiency, bad kidneys.
All things that make major surgery incredibly risky.
Incredibly, these factors drastically elevated the morbidity and mortality of the massive open operation. In some high-risk patient series documented around that time, open aortic surgery mortality could soar to a horrifying figure in excess of 60%.
60% mortality. Let that sink in. 6 out of 10 patients dying from the attempt to fix the aneurysm? That sounds like clinical desperation.
It absolutely was. For those patients who were often the very ones whose aneurysms were growing fastest or becoming symptomatic, open graft replacement was effectively contraindicated. The cure was often just as lethal as the disease itself.
So they were stuck. No good options.
Pretty much. It was an unacceptable risk. And technical issues could compound this too. Things like a hostile abdomen from previous major surgeries, like gastric or biliary operations, causing dense adhesions, or complicated prior vascular reconstructions, making the standard retroperitoneal or transabdominal approach incredibly difficult and dangerous.
And this is where EVAR comes in.
This is where the EVAR solution, treating the condition from within, often under just local or regional anesthesia, offered the only viable path for this rapidly growing population considered unfit for open repair. It wasn't just a cool new tech, it felt like an ethical imperative dressed up as a technological breakthrough.
This expansion of who could potentially be treated also had to be justified by the data showing that these aneurysms were genuinely ticking time bombs, right?
Yeah.
They absolutely needed intervention, even if the patient was high risk.
Yes, the clinical urgency was definitely backed by classic studies that were well known at the time. Silogy's foundational work, for instance, showed that small, surgically untreated aneurysms were the eventual cause of death in nearly 30% of patients, 29.5% to be precise.
So treating them, even if risky, profoundly improved late survival compared to doing nothing.
Exactly. And what about the size argument? Because the conventional wisdom, even well into the 90s, was that aneurysms smaller than, say, 5 or 5.5 centimeters could simply be watched safely. Wait and see.
Was that reliable?
Well, that convention was based on averages, and the sources Parodi and others were looking at show that danger lurked even below that threshold. Darling's widely cited study showed that 18.1% of ruptured aneurysms were actually less than 5 centimeters in diameter when they burst.
Wow, almost 1 in 5 ruptures happened in the supposedly safe zone. That really undermines the wait-and-watch approach for everyone.
It certainly does. And it gets potentially worse. Cronin-Wett's report suggested an even more alarming trend, particularly for patients with high blood pressure.
What did they find?
They found that AAAs as small as 4 centimeters in diameter could be associated with a rupture rate as high as 20% per year if severe hypertension was also present.
20% rupture rate per year for a 4-centimeter aneurysm if you have high blood pressure. That utterly decimates the wait-and-watch philosophy for certain high-risk individuals, doesn't it?
It fundamentally shifted the indication philosophy for many surgeons who were paying attention. These facts argued that the mere presence of an AAA in a high-risk patient, especially one with hypertension and not solely its size, should perhaps be the mandate for exclusion from circulation.
And that ties back into EVAR.
Perfectly, because which lesions are mechanically best suited for a less invasive transfemoral technique, especially in the early days? Often the smaller, less complex aortic aneurysms that haven't completely destroyed the landing zones, the healthy artery above and below yet.
Ah. So the EVAR procedure didn't just solve the problem for the sickest patients unfit for open repair. It philosophically opened the door to treating smaller lesions earlier. An intervention that the massive morbidity of open surgery could never really permit or justify in those cases.
Exactly. This is where the revolution really starts to take shape beyond just the high-risk niche.
Okay, let's go deep into the methodology of the Parodi paper itself now, because the technology they were deploying in 1991 sounds, frankly, astonishingly crude compared to today. Yet the conceptual engineering was somehow faultless.
That's a great way to put it. It was like the difference between a prototype Model T Ford and a modern Formula One car. The core engine design, the concept, was there, but the execution was, well, early.
So how did Parodi and his colleagues actually propose to pull off this procedure? Reconstructing the body's largest artery, using components threaded up through the groin, usually under local anesthesia. It sounds like science fiction for the time.
The procedure they described was transfemoral intraluminal graft implantation. Basically, they used retrograde cannulation going backwards up the common femoral artery in the groin. The entire purpose was to exclude the aneurysm sac from blood flow from circulation by relying on friction seals.
Friction seals. Not sutures.
No sutures inside the aorta. The seals were created by a metal stent expanded inside the artery, fixing the graft material to the relatively healthy native aortic wall above and below the aneurysm bulge.
Let's focus on the device itself then. This wasn't something you could just order from a catalog, was it?
Oh, far from it. This was a bespoke, handcrafted device, individually tailored for each patient. The components were revolutionary for the application, but required manual assembly right there.
What were the components?
They utilized a tubular knitted Dacron prosthetic graft, a standard vascular graft material, but a thin-walled, crimped version specifically designed to be compressible. That was key.
Okay.
Then, crucially, they sutured by hand a modified Palmaz balloon-expandable stainless steel stent onto the proximal end, and often the distal end as well, overlapping the ends of this Dacron graft.
So they were taking a Palmaz stent, which I think was primarily designed for smaller arteries, maybe even coronary applications around that time.
That's right.
And essentially turning it into the anchoring mechanism for the aorta, the biggest artery in the body.
Precisely. The Palmaz stent had to be modified to handle the forces and dimensions of the aorta. And yes, the anchor was everything. When that stent was expanded by a balloon, it exerted radial force outward pressure, creating that friction seal, pressing the Dacron graft material firmly against the inner aortic wall.
Effectively replacing the need for surgical sutures entirely, at least for the main attachment.
Exactly. This allowed them to eliminate the need for an open anastomosis, the surgical sewing part. That was the core innovation.
Okay, device figured out, sort of. What about the delivery system? How did they get this Dacron stent hybrid thing up into the aorta? You mentioned it was massive.
Massive is an understatement by today's standards. To thread this whole assembly up from the groin, they had to use a very large, stiff Teflon sheath. It was a number 22 French in size.
22 French, how big is that?
It's about 7.3 millimeters in outer diameter, huge for an artery access sheath, and it was 45 centimeters long. It had to be introduced through a surgical cut-down and open incision onto the femoral artery. You couldn't just stick it in percutaneously like we do now.
Wow. And deployment.
To deploy the device, the entire stent graft assembly was mounted onto an enormous valvuloplasty balloon catheter, the kind used to stretch open heart valves measuring 23 or even 25 millimeters in diameter when inflated.
Huge balloon.
Massive. And placement was done entirely under fluoroscopy live X-ray, using contrast dye injections to identify the renal arteries to make sure they didn't cover them up, and the iliac bifurcation down below.
That number 22 French sheath really jumps out as a monumental technical hurdle.
Right.
Just for context, modern EVAR devices are often delivered through sheaths as small as 14 or even 12 French now.
Right, much, much smaller.
So this immense size must have dictated everything about patient selection back then, because navigating a rigid #22 French sheath through anything but a perfectly straight wide artery sounds extremely difficult, if not impossible.
It was the single biggest limitation, absolutely. The technology dictated the anatomy they could treat, not the other way around. And the device itself, remember, had to be customized, the diameter, the length, based on meticulous preoperative imaging, sonography, CT scans, arteriograms, for every single patient.
They couldn't just pull a size medium off the shelf.
No way. Each one was basically a custom job.
Now, this wasn't something they just dreamed up and tried the next day in a patient, surely. How much preclinical work, how much animal lab work underpinned this massive human experiment?
Yeah, the source material is quite clear that the initial conceptual exploration started way back, as early as 1976. So this concept evolved over a solid 15 years in experimental settings before the first human was ever treated.
15 years. What were the key evolutionary steps they had to solve in the animal labs during that time? What were the big hurdles?
Well, there were three major technical problems they had to crack. First, they had to figure out how to process and debulk the Dacron prosthesis. Remember, it's a fabric, so it could be folded tightly, packed down, and then implanted through a sheath without tearing or snagging. Miniaturization, essentially.
Okay, getting the graft small enough. What else?
Second, they had to figure out how to modify those Palmaz stents to create a reliable and durable anchoring system for the Dacron graft in the aorta. This wasn't easy. The stent had to hold that graft firmly in place against the massive systolic pressure, the heartbeat pulse of the aorta day in, day out.
Right, the forces are huge. And the third step, they had to prove the whole concept actually worked in vivo, in a living system.
Yes. And this was ingenious. They had to create artificial AAAs in experimental animals. Specifically, they surgically replaced a segment of the infrarenal aorta in dogs, I believe, with a fusiform-shaped Dacron conduit, basically sewing in a bulge, just so they could then practice deploying their device inside this artificial aneurysm.
To prove that intraluminal exclusion of the sac was physically possible.
And biomechanically sound. That confidence, gained through 15 long years of animal testing and refinement, is what finally led them to attempt the first in-man trials.
Now, let's discuss those first 5 patients. Their profiles are just a stunning demonstration of the clinical desperation involved, and also the team's dedication to only treating patients who truly had no other hope.
Absolutely. These were not elective routine cases by any stretch. They were truly complex, high-risk individuals, and all were treated under local or regional anesthesia specifically because they were deemed too fragile for the massive physiological trauma of open repair.
Tell us about patient number 1.
Patient number 1 was a 70-year-old man. He had severe COPD, chronic obstructive pulmonary disease, and a 6-centimeter AAA. The defining factor here, he explicitly refused standard open surgery, understanding the extremely high respiratory risk involved for him.
So he opted for the experimental procedure.
He agreed to the EVAR under epidural anesthesia. The procedure itself was successful in excluding the aneurysm. The learning curve complication was local. He developed a post-operative groin hematoma at the access site that required subsequent surgical evacuation. But critically, he avoided the systemic trauma, the lung complications they feared.
Right, the systemic result was successful, even if the access site had a predictable hiccup. But patient 2 provided what I think is maybe the most dramatic and scientifically crucial learning moment of the entire series.
Ah, yes, patient 2, a 68-year-old man, also with a 6-centimeter AAA. They went in to implant a single stent graft combination. However, during the procedure, due to technical difficulties, they specifically noted an accidental displacement of the marking ruler they were using under fluoroscopy. The stent was deployed about 3 centimeters distal or lower down than the plant site.
What did that mean clinically?
It meant the graft extended too far down and effectively excluded or blocked off the contralateral common iliac artery, the blood supply to the other leg. This immediately created an acute surgical emergency, ischemia.
Oh, wow. So a catastrophic failure of placement. What was the immediate recourse? They had to fix it, right?
Absolutely. Immediate conversion to standard open surgery was required right then and there to restore flow to the leg. This must have been a massive setback for the team, a real oh-no moment.
You'd think, but...
But here is the profound scientific silver lining. During the open surgery, when they went to remove the misplaced endovascular device, they found that the Palmaz stent and its Dacron covering were so firmly attached to the inner wall of the aorta.
Even though it was diseased aorta?
Exactly. It was so firmly embedded that it required formal, laborious surgical resection to get it out, like it was part of the artery wall.
Wait, so the failure to place it correctly actually proved the fundamental success of the core concept?
Precisely. The complication unintentionally confirmed the core principle. It proved, definitively, that the stent graft concept relying on that radial force, that friction seal, was robust enough to anchor itself securely to the diseased aortic wall and withstand the body's massive hydraulic forces. It wasn't just going to slip or blow out.
That must have given them immense confidence, ironically.
Huge confidence, despite the immediate surgical problem. Confidence to move forward with refining the technique and placement accuracy. It's a truly fascinating moment in medical innovation, a failure that was simultaneously a powerful validation.
Incredible. Now, patient 3 was different. Again, sounds like an acute rescue mission in a patient with severe neurological injury already.
Yes, a very complex case. A 63-year-old man suffering from a massive hemorrhagic infarction, a type of stroke. While hospitalized for that, he developed acute abdominal pain, which was quickly revealed to be an acute AAA dissection, a tear in the inner lining of his aortic wall, which is often rapidly fatal.
And open repair was out of the question.
Truly prohibitive due to his critical neurological status. He likely wouldn't survive the anesthesia or the operation. So Parodi's team chose the transfemoral approach as a last resort.
The ultimate high-risk scenario, really. What did they do?
In this instance, they utilized only a proximal stent without the full Dacron graft, primarily to seal the entry tear of the dissection. The good news: the stent successfully sealed that proximal intimal disruption. His pain subsided almost immediately, and imaging showed the false lumen thrombosed and the aorta's overall diameter dramatically diminished.
So it worked for an acute aortic catastrophe, too.
It demonstrated the potential power of EVAR not just for chronic stable aneurysms, but for acute aortic syndromes in patients who simply could not be cut open, another expansion of the potential indications.
Okay, patients 4 and 5 seem to round out the picture. Tell us about patient 4.
Patient 4 was a 61-year-old man, severe asthmatic with COPD, also high risk for open surgery, with a 6.5 centimeter AAA. His procedure required a second distal stent placement because the initial proximal stent graft didn't achieve a perfect seal. There was some initial reflux or leak noted, so they learned they might need more than one stent sometimes.
And patient 5. This one highlights another potential use treating complications other than just size-related rupture risk.
Exactly. Patient 5 was a 62-year-old man with extreme non-correctable coronary artery disease. His cardiac ejection fraction, a measure of heart pump strength, was less than 20%, which is very low. He was also suffering from recurrent episodes of atheromatous embolization.
Trash foot or blue toe syndrome.
Precisely. Little bits of cholesterol plaque or clot showering down from his aorta into his legs, causing pain, discoloration, tissue loss.
Right.
His AAA was actually quite small, only 3.8 centimeters, but its irregular inner surface suggested it was the source of these dangerous emboli.
So they weren't intervening primarily for rupture prevention here, but for limb salvage and systemic protection in a patient who would almost surely die if subjected to open aortic repair.
Exactly. It was a totally different indication. After stabilizing him from a recent episode of pulmonary edema, they went ahead and implanted a double stent combination, proximal and distal. The outcome was highly successful. He had no recurrence of distal embolization after the implantation.
That's huge. It dramatically expanded the philosophical scope of EVAR right from the beginning. It showed it could potentially treat symptomatic, even smaller lesions in very high-risk patients. It proved it was a tool for more than just managing the size of the bulge.
Yeah, it really broadened the horizon.
So, looking at those 5 initial, frankly desperate cases, the immediate advantages, despite all the technical hurdles like that enormous #22 French sheath, they seem pretty clear.
Oh, they leaped off the page of the paper. The core benefits were immediate and obvious. The lack of aortic cross-clamping, that alone was revolutionary. And the avoidance of high regional or general anesthesia in most cases.
And how did that translate clinically for these fragile patients?
Directly and immediately into lower cardiovascular stress, lower respiratory complications, and less renal strain or kidney injury. These are the very systems, heart, lungs, kidneys, that failed and caused that horrifying 60% mortality rate in the sickest open surgery patients. EVAR just bypassed much of that systemic hit.
Were there other, maybe more subtle, but still important potential long-term benefits they noted?
Yes. There's the avoidance of trauma to the delicate periaortic and periiliac autonomic nerve plexus. Open surgery, especially deep dissection around the aorta and iliac arteries, often risks damaging these nerves.
Leading to problems like?
Well, particularly retrograde ejaculation in men, which can be a significant quality of life issue. The endovascular approach, staying inside the vessel, bypassed this risk entirely.
That's a big deal. Anything else?
And also, financially and physiologically significant, was the fact that 4 out of the 5 initial patients were treated without requiring a single unit of blood transfusion. They could reverse the heparin anticoagulation at the end of the procedure. This was a stunning contrast to the massive blood loss typically seen, or at least prepared for, in complex open aortic reconstruction back then.
Huge advantages. But of course, no pioneering procedure is perfect, especially one developed with such crude, customized hardware. The Parodi paper was, commendably, very honest about the significant technical unknowns and the caveats that the medical community still needed to solve, wasn't it?
They were completely forthright about what they didn't know yet, which is the mark of good science. For example, they were using a thin-walled knitted Dacron graft. The tendency of this type of fabric to dilate, to stretch out over time, when exposed constantly to massive arterial pressure, is historically well known from open surgery experience.
Right, grafts could get bigger over years.
So the question they posed directly was, if we place this potentially dilatable material within an already dilated aorta using the graft inclusion technique, will this somehow prevent the material itself from expanding further over time? Or will the whole construct just get bigger?
A critical question for long-term success. What was their short-term observation on that?
Encouragingly, they reported no graft dilation had been seen in their initial, albeit short, follow-up. They also noted very positively that the excluded aneurysm sac, now filled with thrombus and cut off from direct flow, appeared to stabilize and perhaps even fibrose and diminish in diameter over time. That suggested healing, which is highly desirable.
But they admitted the long-term was unknown.
Absolutely. They clearly acknowledged that long-term material durability and the potential for material fatigue remained an entirely open question that only time and more patients could answer.
And then there's the concept that has, frankly, plagued EVAR success ever since day one, the endoleak. The idea that the exclusion might not be complete or durable.
This paper is really the birth of the endoleak problem as a defined clinical entity. They questioned directly whether patent lumbar arteries, small branches coming off the back of the aneurysm sac, or the inferior mesenteric artery, IMA, which supplies the bowel, would continue to perfuse the excluded sac even with the graft in place.
Thereby maintaining pressure inside the sac.
Exactly. Maintaining pressure and potentially risking continued aneurysm expansion even though the main flow was through the graft. While they theorized that thrombosis and occlusion of these side branches might follow intraluminal graft placement, the immediate and long-term effect was completely unknown.
This is the absolute genesis of the type 2 endoleak discussion, isn't it?
Mhm.
Blood flow into the sac from collateral vessels.
Absolutely. The Parodi paper, simply by raising the question based on anatomical principles, forced all future research and development to focus intensely on sac perfusion dynamics and endoleak detection and management.
And it wasn't just side branches, right? What about leaks at the ends of the graft?
Right. Furthermore, they had no way of knowing if the mechanical friction seal itself, the attachment points at the top and bottom, what we now call the source of type I endoleaks, would fail over time due to stent migration, the device slipping, or the aortic neck itself dilating further. The long-term durability of that initial friction-fit seal was completely untested territory.
And one more risk.
Yeah.
The risk of embolization, which was the very thing that made Dotter's original angioplasty concept folly to the surgeons back in 1964. Did that concern apply here?
Definitely. The risk of distal embolization sending debris downstream from the intraluminal thrombus that lines almost all aneurysms remained an acknowledged possibility during the manipulation required to place the device.
Because you're maneuvering this big device through a sac full of clot.
Exactly. They noted that aneurysms are often full of loose, friable debris. They hoped that maintaining a stiff Amplatz guide wire parallel to the aortic wall during device passage would help minimize dislodgement. But they were acutely aware that this manipulation, especially with that huge, stiff #22 French sheath, could potentially shower the legs with thrombus. Fortunately, they didn't observe it in these first 5 cases, but the risk was clearly stated.
Okay, let's circle back for a moment to the anatomical requirements. These are often overlooked when we just talk about the revolutionary concept, but they were incredibly important in the beginning. The technology dictated the patient selection, not just the pathology.
Hugely important. The initial Parodi procedure was extremely restrictive, anatomically speaking, precisely because that huge #22 French delivery system simply couldn't handle curved, calcified, or short aortas or iliac arteries. The procedure demanded very specific, almost pristine anatomical constraints for secure fixation and device delivery.
Can you give us the numbers again? Because
Yeah.
they really are staggering compared to modern practice where we can treat much more complex anatomy.
Sure. They required a section of relatively normal aortic wall, the landing zone for the stent. That was at least 3 centimeters in length proximally, meaning below the renal arteries but above the aneurysm bulge, and at least 2 centimeters in length distally near the bifurcation into the iliac arteries.
3 centimeters of healthy neck below the renals. That's a luxury. Most diseased aortas don't present with that perfect 3-centimeter healthy segment, do they?
Precisely. That requirement alone excluded a huge number of patients. And the iliac arteries, the arteries in the pelvis leading down from the aorta, were the second major anatomical bottleneck.
What were the requirements there?
They had to be patent, open, or at least amenable to simple angioplasty to open them up. But most importantly, because of the delivery system, they had to be straight or nearly straight.
No curves.
Very little. An elongated, tortuous, meaning curvy or heavily calcified iliac artery would simply prevent the passage of that large, stiff #22 French sheath entirely. It just wouldn't make the turn.
So the ideal candidate was incredibly specific back then.
You got it. If the patient had perfect, straight, wide arteries with long landing zones and was simultaneously too sick for open repair, then they qualified. If they were sick but had tortuous vessels or a short neck, they were unfortunately out of luck in 1991.
This really contextualizes the powerful commentary that accompanied the original Parodi paper, doesn't it? It was written by Dr. John J. Bergen, who was an absolute titan of vascular surgery at the time. He didn't just review the data, he seemed to understand the implications immediately and predicted the future.
Oh, Bergen's commentary is one of the most prophetic pieces of medical writing from that entire decade, I think. He framed the work not just as a technical feat, although it was, but as an artistic and scientific simplification of complex aortic surgery. He immediately grasped the magnitude of the conceptual shift, even with all the limitations.
What was his main prediction? The one that truly sets this concept apart as revolutionary, even in its infancy.
His prediction was essentially twofold, and history proved both parts were spot on. First, he stated the obvious. The procedure would inevitably be offered initially only to those patients at prohibitive risk for conventional surgery, exactly like the 5 patients Parodi treated, the no other option group.
Okay, that makes sense. But the second part?
His second and far more profound prediction was this, and I'm paraphrasing slightly. As experience grows, it will inevitably be offered to patients who are good surgical risks, even those with aneurysms smaller than the ones conventionally requiring surgical repair based on size alone.
Wow. He foresaw the migration of the procedure from being just a desperate rescue mission for the unsalvageable to becoming the standard elective first choice for almost every patient, regardless of their surgical risk profile. He saw the future of the entire specialty changing.
He absolutely did, and he also foresaw the inevitable resistance from the traditionalists, just as Daughter had faced with angioplasty decades earlier. He actually wrote something like, "Opposition to the procedure will be mounted." He knew it was coming. But new applications, including perhaps transliminal distal bypass, are predictable.
He even predicted future endovascular procedures beyond AAA repair.
Yeah. And he concludes with this powerful, almost philosophical sentiment that really applies to all medical innovation. He said, specific to vascular surgery, no change for the better has occurred that wise and good men have not opposed.
That single sentiment just captures the entire story arc of innovation, doesn't it? From Daughter's perceived folly to Parodi's revolution. The procedure essentially created its own future roadmap right there in the 1991 paper and commentary, anticipating the next 3 decades of evolution, from intense skepticism to near ubiquity.
The very fact that Bergen, a highly respected open vascular surgeon, could instantly recognize that this cumbersome early-stage #22 French procedure would eventually challenge and likely supersede the gold standard of open repair for many patients. That just shows how fundamentally revolutionary the underlying concept was, regardless of the initial hardware limitations.
Okay, let's try and pull all of this deep dive together now as we wrap up. We've journeyed from Eastcott, establishing the high-stakes open surgical domain for carotids, to Daughter establishing the radical, initially scorned endovascular access concept with angioplasty.
Right.
Through the clinical necessity dictated by those terrifying 60% mortality rates in sick patients needing open AAA repair.
The driving force.
Culminating in Parodi's brilliant 1991 synthesis, applying Daughter's concept to the aorta's biggest problem.
And based on that journey, I think we can confidently confirm our initial thesis, can't we? The Parodi paper stands as the most seminal event for the specialty in the last century because it forced the entire field to evolve. It wasn't just an option, it demanded change.
How so?
It forced the specialty to transform from being an exclusively open surgical craft to becoming a hybrid discipline that required mastery of both the knife and the wire, the catheter, the image intensifier.
Yeah.
It didn't just add a new tool to the toolbox, it fundamentally changed the definition of what a vascular surgeon was and what they needed to be able to do.
It redefined what was physically possible inside the aorta, really. Before Parodi, the only durable solution for a lethal AAA was a massive knife, a clamp across the aorta, and hours of complex stitching under immense physiological stress.
And after Parodi, the idea existed that a catheter inserted through the groin could potentially achieve the same critical exclusion of the aneurysm, provided you had the perfect anatomy initially.
And it's absolutely critical to remember where this revolution started, isn't it? A massive, handmade Dacron Palmaz graft cobbled together,
Deployed through a giant, stiff #22 French sheath.
requiring strictly straight, non-tortuous iliac arteries and those long, healthy aortic necks for landing zones.
The technology was undeniably crude by today's standards, almost primitive. But the concept, the idea of intraluminal exclusion, it was flawless, and that's what mattered.
Which raises the final provocative thought we want to leave you, the listener, with today. Think about this. Parodi's initial concept brought aortic surgery out of the main operating room and into the catheter lab or angiography suite. at least for the sickest patients who happen to have that perfect straight anatomy.
So the question becomes, what further specific technological improvements were immediately unlocked, or rather demanded, by Parodi's conceptual leap? Consider the obvious limitations: the massive delivery system, the need for enhanced sealing technology beyond simple friction.
How did overcoming those specific initial hurdles, the drive for miniaturization, for better sealing, for treating more complex anatomy, how did that relentless technological push, sparked by this 1991 paper, fundamentally alter the curriculum and the required skill set for every single future vascular surgeon?
Yeah, think about the shift in training. Moving priority from just perfecting open incision and exposure and technical knot tying mastery under pressure.
To also mastering complex YO and catheter skills, navigating tortuous vessels, and interpreting three-dimensional imaging in real time to guide interventions from the inside out.
Those initial technical constraints of 1991, the huge sheath, the need for straight arteries and long mechs, they were essentially the world's most detailed market research report for the medical device industry.
Saying, here's the billion-dollar problem you need to solve.
Exactly. Once the core concept was proven feasible, even with that crude, huge device, the race was well and truly on. To shrink the sheath, to improve the seal, to make grafts conformable, to eliminate those strict anatomical constraints. That relentless drive, fueled directly by the potential shown in the Parodi paper, is what truly redefined vascular surgical training and ultimately opened the technique up to almost every patient, regardless of their surgical risk or their specific anatomy.
A singular article providing the impetus for an entire industry and fundamentally changing the definition of a surgical specialty forever.
That's why it's seminal.